Today we'll be looking at the ESC guidelines 2024 on the management of chronic coronary syndrome, and Dr. Freedom Enero will be taking us. So we'll just listen aptly and then make our contributions, questions at the end of the presentation. Thank you. And Dr. Freedom, the floor is yours.
All right, thank you. A very good evening to our consultants and teachers in the house, fellows, our chiefs, and colleagues. So, like I was said, today, as part of our guidelines presentation, today we are talking about the 2024 ESC guidelines on management of chronic coronary syndrome. And as usual, we want to start by introducing these terms that we always talked about, talking about the classes of evidence. Sorry, talking about the levels of evidence, that has levels of recommendation, and the classes of recommendation. Like we said before, class one means um, when the evidence or when there's an evidence or general agreement that a given treatment or procedure is beneficial, useful, or effective. Usually, this class one tells you that the evidence or the evidence is recommended or is indicated. Then class two is when conflicting evidence or divergence of opinion about the usefulness or efficacy of a given treatment or procedure. Class two is divided into 2A and 2B, as we all know. For 2A, the evidence that about the usefulness or efficacy of the given treatment or procedure should be considered. While class 2B, the evidence for usefulness or efficacy of the given treatment procedure may be considered. Then for class 3, the evidence or general agreement that the given treatment or procedure is not useful and in some cases it may be harmful. Then for levels of evidence, we have level A, B, and C. The level A level A simply means the data derived from multiple randomized controlled trials or meta-analysis. Then for level B, data are derived from a single randomized controlled clinical trial or large non-randomized studies. Then level C, there's consensus of opinion of the experts or small studies or retrospective studies and registries. Then this is the outline that will follow: introduction, pathophysiology, epidemiology, clinical presentation, approach to patients with chronic coronary syndrome, the guidelines and conclusion. So we just want to give an overview of chronic coronary syndrome before going to the bit of the matter, as the 2024 guidelines on management of coronary syndrome. Based on expanded pathophysiology concept, a new and more comprehensive definition of chronic coronary syndrome has been introduced. It's described as a range of clinical presentations or syndromes that arise due to structural and or functional alterations related to chronic disease of the coronary arteries and or the microcirculation, and said that these alterations can lead to transient reversible myocardial demand versus supply mismatch, thereby resulting in hypoperfusion, which may be provoked by exertion, as physical exertion, emotional stress, or physical stress, and may manifest as angina, other chest discomfort, or dyspnea, or may be asymptomatic. Sometimes they can even present with dizziness, which is one of the angina equivalents. Although stable for prolonged periods, chronic coronary syndromes are frequently progressive and may destabilize at any moment with development of acute coronary syndrome. The 2019 European Society of Cardiology Guidelines for Diagnosis and Management of Chronic Coronary Syndrome introduced the term chronic coronary syndrome to describe clinical presentations of chronic coronary artery disease during stable periods, particularly those preceding or following an acute coronary syndrome. Then coronary artery disease was defined as the pathological process characterized by formation of atherosclerotic plaque in the epicardial arteries, whether it is obstructive or non-obstructive. It is said to be associated with an inadequate supply of blood to the myocardium due to obstruction of the epicardial arteries usually from atherosclerosis. However, it's it's this particular pathological process is characterized by atherosclerotic plaque accumulation in epicardial arteries may be non-obstructive. So we can have obstructive coronary artery disease and non-obstructive coronary artery disease, which we'll talk about later. Talk about the ANOCA, angina with non-obstructive coronary artery disease, or INOCA, INOCA, that's ischemia with non-obstructive coronary artery disease. The patient may be stable or unstable. Patient with coronary artery disease may be stable or unstable. For the stable patients, those group of patients, those are the ones that are referred to as having coronary artery disease. While the unstable patients, what usually they present with symptoms of acute disease. Until recently, coronary artery disease was a disease spectrum that covers stable angina, acute coronary syndrome. In fact, in the past, chronic coronary artery disease was also said to constitute a sudden cardiac death. In 1970s, the classification of chronic coronary syndrome coronary artery disease was divided into likely coronary artery disease, probable coronary artery disease, possible coronary artery disease, and sudden cardiac death. Whereas stable angina presupposes a mild, non-progressive disease with minimal threat to life. Acute coronary syndrome connotes a grave and life-threatening disease, end of the spectrum. In 2018, the European Society of Cardiology introduced a new name for stable coronary artery disease, one that actually brings the nomenclature more in line with contemporary understanding of its development, progression, and management. The ESC first published guidelines incorporating the name chronic coronary syndrome, that is typographical error, recognizes coronary artery disease as a dynamic process of atherosclerosis and altered arterial function that can be modified by lifestyle, pharmacological therapies, and revascularization, which results in disease progression or regression. So before now, it was thought to be perhaps a stable process, but now this chronic coronary syndrome is now known to be a dynamic process. That is the process is not just a stable one where there's just formation of plaque that is not progressive or getting worse. So for chronic coronary syndrome, the process is said to be dynamic, so it's progressive. However, coronary artery disease is dynamically progressive. Its natural history gives us some insight as to why the term stable angina may be misleading. It is worthy of note that the disease is chronic, most often is progressive and ends serious, even though there are clinically apparent silent periods or stable states. So, like I said earlier, the term stable angina, which has been placed with chronic coronary syndrome, is misleading, considering the fact that it's now known that patients with stable angina that are not in a dynamic state, the process is progressive. Because the term angina, stable angina, implies a low risk and less urgency in ACT management is usually stable. People assume that if you say a patient has stable angina, patient is not, there's really no urgency there, because we said that the patient is not really in any form of distress, and we tend to think that the patient is unlikely to deteriorate or present with symptoms of acute coronary syndrome. Plus, there's a change in the nomenclature. Now, coronary artery disease now covers acute coronary syndrome and chronic coronary syndrome, where acute coronary syndrome is further divided into the unstable angina, and that is not divided into unstable angina, NSTEMI, and STEMI. Understanding of the pathophysiology of chronic coronary syndrome is transitioning from a simple to a more complex and dynamic model. Other concepts consider a fixed focal flow limiting atherosclerotic stenosis of a large or medium coronary artery as a must for indicible myocardial ischemia and ischemic chest pain. However, current concepts embrace structural and functional abnormalities in both the macro and microvascular compartments of the coronary artery tree that may lead to transient myocardial ischemia. At the macrovascular level, it's not only fist. However, there is also a flow-limiting stenosis, but also diffuse atherosclerotic lesions without identifiable luminal narrowing may cause ischemia under stress. So at macrovascular level, it's not the only fist obstruction that can cause ischemia. However, flow-limiting stenosis or patients that does not have any form of luminal narrowing can also present with symptoms. Then structural abnormalities such as myocardial abrasion and congenital arterial anomalies or dynamic epicardial vasospasm may be responsible for transient ischemia. While at the microvascular level, coronary microvascular dysfunction or coronary microvascular diseases are increasingly acknowledged as the prevalent factor characterizing the entire spectrum of chronic coronary syndrome. Functional and structural microcirculatory abnormalities may cause angina and ischemia, even in patients with non-obstructive disease of the large or medium coronary arteries, as is seen in patients with angina with non-obstructive coronary arteries, that's ANOCA, or ischemia with non-obstructive coronary arteries, that is INOCA. Systemic or extra coronary conditions such as anemia, tachycardia, blood pressure changes, myocardial hypertrophy, and fibrosis may also contribute to the complex pathophysiology of non-acute myocardial ischemia. Like I have explained earlier, this thematic diagram has given us an idea of what the pathophysiology is like in patients with chronic coronary syndrome. There is narrowing of the coronary arteries, thereby leading to insufficient blood flow, and this results in an imbalance between myocardial oxygen demand and supply. So most times the demand usually exceeds supply, thereby resulting in symptoms. There is anaerobic metabolism because of reduction in blood supply to the myocardium, thereby resulting in accumulation of lactic acid. Then the myocardial nerve are irritated, thereby giving rise to the symptoms that we see in them, the pain. This is another figure showing risk factors, clusters of risk factors that lead to these both obstructive coronary artery disease or non-obstructive coronary artery disease. These factors such as hypertension, dyslipidemia, diabetes, inflammation. The epidemiology: coronary artery disease is leading cause of death worldwide and in Europe. Globally, cardiovascular diseases, including coronary artery disease, is responsible for 72.7 million hospital admissions in 2017, of which 18 million of these patients are in Europe. In the United Kingdom, an estimated 2.3 million people are living with coronary artery disease. In England and Wales in 2018, coronary artery disease is now only second to dementia and Alzheimer's disease as the current leading cause of death. The prevalence of stable coronary artery disease increases with age in both sexes, that's in both male and female, with women aged 45 to 64 years having a prevalence of 5 to 7%, and men having a prevalence of 4 to 7% that's for men and women of the same age group. There is a steady increase to 10 to 12% for women aged 65 to 84 years and 12 to 14% in the same age range for men. Coronary artery disease is among the leading cause of death in Nigeria, accounting to about 4.37% in studies done in 2019. In 2020, WHO, World Health Organization, published that death in coronary artery disease was about 61,374 per year, which ranked Nigeria as number 107 in the world. Clinical presentation of patients with chronic coronary syndrome. In clinical practice, the symptoms are not entirely exhaustive. However, patients with chronic coronary syndrome usually seek outpatient medication. These are the spectrum of patients with chronic coronary syndrome seeking outpatient medication, outpatient medical attention rather. One, asymptomatic patients with reproducible stress-induced angina or ischemia having epicardial obstructive coronary artery disease. Two, the patient with angina or ischemia caused by epicardial vasomotor abnormalities or functional and structural microvascular alterations in the absence of an obstructive coronary artery disease. Three, the non-acute patients post acute coronary syndrome or after a vascularization. Then also the non-acute patient with heart failure of ischemic or cardiometabolic origin might also present in clinic with symptoms related to acute coronary syndrome. Sorry, chronic coronary syndrome. Sex stratified analysis indicate that women with suspected angina are usually older and have heavier cardiovascular risk factor burden, more frequent comorbidities, non-angina symptoms such as dyspnea and fatigue, and greater prevalence of um, chronic coronary syndrome symptoms than men. It's said that women usually present with the angina equivalent like dyspnea, fatigue. Some of them present with dizziness. Some of them present with backache, just pain in lower jaw or the tip of the shoulder without the classical chest pain. These characteristics of angina that usually seen patients present with chronic coronary syndrome. Characteristics with regards to the location, character, duration. He said that the chest pain is near the sternum. They may be felt anywhere from the epigastrium to the lower jaw or teeth, between the shoulder blades, or in either arm to the wrist and fingers. The discomfort is often described as pressure, tightness, or heaviness, sometimes strangling, constricting, or burning. The duration of the discomfort is brief, usually less than 10 minutes in majority of cases, and more commonly just a few minutes or less. And chest pain lasting for about for just few seconds is unlikely to be due to coronary artery disease. Clinical classification of suspected angina symptoms. The angina symptoms are usually classified into typical symptoms, atypical angina, or patients having non-angina chest pain. Usually, if the patient meets these three criteria that I'll mention, the patient is said to have typical angina pain. If they meet only two of the criteria, the patient is said to have atypical angina pain. However, if they meet only one or none of the characteristic chest pain, the patient is said to have a non-anginal, non-cardiac chest pain. The criteria are: one, constricting discomfort in front of the chest or in the neck, jaw, shoulder, or arm. Two, this discomfort is usually preceded by physical exertion or emotional stress. Three, following discomfort, patients get some relief from when they have rest or when they are given nitrates. So if a patient has these three characteristics, having the constricting discomfort in front of the chest, usually preceded by physical exertion or emotional stress, and relieved by rest or nitrate within 5 minutes, the patient is said to have typical angina chest pain. However, if a patient has just two of these three characteristics, the patient is said to have atypical angina chest pain. However, if a patient meets only one, or patient does not have any of these characteristics, then patient is said not to have an angina chest pain. These are activities that usually present angina. The activities include physical exertion, cold exposure, following heavy meals, and intense emotion. So there's also the nocturnal angina, which usually felt at night when patient is sleeping. Then the decubitus angina when patient lies flat. So these are some of the symptom characteristics that I just mentioned. Talk about the quality of the pain, like we described earlier. This is on the first side, on your left side of your screen or left side of your phone. The quality, location, and size, duration, trigger, and relief are described in decreasing likelihood of chronic coronary syndrome, while on the right side are described in increasing likelihood of chronic coronary syndrome. So we talked about the policy of the pain earlier on, then the triggers, then things that can relieve those pains. What are risk factors for coronary artery disease? Risk factors can be modifiable and non-modifiable. Non-modifiable risk factors include family history of coronary artery disease, increasing age, male gender, then race, usually in Black population. The modifiable risk factors include high blood cholesterol, cigarette smoking or tobacco use, hypertension, diabetes mellitus, lack of estrogen in women, physical activity, that's physical inactivity, obesity. So this figure classifies these factors into traditional risk factors and non-traditional risk factors. With traditional risk factors including age, diabetes, smoking, hypertension, dyslipidemia, obesity, premature family history of coronary artery disease, All these through some mechanisms leads to atherosclerosis and formation of atherothrombosis that finally leads to occlusion of the vessel. Patient presents with symptoms of coronary artery disease. The non-traditional risk factors as shown: the abnormal ankle breaker index, patients with hyperhomocystinemia, patients with left ventricular hypertrophy, and CKD patients with microproteinuria as defined by elevated abdominal creatinine ratio. How do I approach a patient with chronic coronary artery disease? Step one, the first step is a general clinical evaluation that focuses on assessing symptoms. This is the next slide, please. Next slide. Okay. The first step is a general clinical evaluation that focuses on assessing symptoms and signs of chronic coronary syndrome, differentiating the non-cardiac causes of chest pain, and ruling out acute coronary syndrome. Then the initial clinical evaluation requires recording a 12-lead resting electrocardiogram, basic blood tests, including your full blood count, thyroid function test, left lateral creatinine, troponin, and high-sensitive cardiac troponin. Patient may also need to do a chest X-ray, pulmonary function test to rule out of chronic obstructive pulmonary disease, which can be a comorbidity in patients with chronic coronary syndrome. This evaluation can be done by the GP, general practitioner. For the second step, there is further cardiovascular examination, including general examination, physical examination, then echocardiography to rule out a left ventricular dysfunction and valvular heart disease. Following that, it's recommended to estimate the clinical likelihood of obstructive coronary artery disease to guide either deferral or referral. Thereby, this is talking about using your pre-test probability. If the patient has symptom characteristics of chronic coronary syndrome, classical symptoms like I mentioned earlier, so this increase the likelihood or chance that the patient will have obstructive coronary artery disease. Then that will tell you that you need to do further testing to actually make your diagnosis. However, if patient has a lower pre-test probability that the patient has chronic coronary syndrome, there might be no need for you to go ahead with doing those confirmatory testing. However, for patients that we usually investigate are patients that have moderate pre-test probability in which we are not sure whether the patient has coronary artery disease or patient does not have coronary artery disease. So for those patients, we want to be sure by doing the investigations, which can be invasive or non-invasive, including your blood workups. Then the third step involves diagnostic testing to establish the diagnosis of chronic coronary syndrome, as I mentioned earlier, and to determine the patient's risk for future events. Then the final steps includes lifestyle and risk factor modification combined with disease-modifying medications. A combination of anti-angina medications is frequently needed, and coronary vascularization is considered if symptoms are refractory to medical treatment or if the patient is at higher risk of coronary artery disease. If symptoms, however, persist after obstructive coronary artery disease is ruled out, coronary microvascular disease and vasospasm should be considered, which this can be done or can be confirmed using invasive coronary angiography. So this is a figure showing what I just mentioned, the initial step involving non-cardiac, patient presents with non-cardiac reasons for the symptoms identified. Patient, they take a history, they take a history of the symptoms, do physical examination, do resting ECG, do your blood workup, do pulmonary function test, chest X-ray. Then in step 2, we assess clinical likelihood of obstructive coronary artery disease. You do an echo at rest, can do an exercise ECG. Essentially, is what I talked about in the previous slide. So this is a figure schematic diagram showing what an angina chest pain feels like. On the left side of the screen, see patient presenting with angina chest pain, usually retrosternal. The patient on the other one, the next one, see the patient feeling sense of pressure within the chest. Then for the next one on blue, the patient in blue t-shirt, this patient is having squeezing sensation in the chest. Then some might present with symptoms of indigestion. these some of the angina equivalents. While some may present with pain that spreads to the neck, lower jaw, arms, back, or belly. Then, like I mentioned earlier, some may just present with dizziness or dyspnea. So these schematic visualization just shows the typical location of the chest pain and where the pains radiate to in patients with chronic coronary syndrome. So this slide tells us about the grading of angina. It's graded from 1 to 4. In grade 1, the patient has angina with strenuous exertion. In grade 2, the patient has angina with moderate exertion. In grade 3, patient has angina with mild exertion. Then grade 4 is angina at rest. So angina with strenuous exertion is 1, with moderate exertion, grade 2, with mild exertion, grade 3. And when patient has angina at rest, patient is said to have grade 4 angina according to the Canadian Cardiovascular Society. So let's move to the next slide. Next slide, please. So how do you manage patients with chronic coronary syndrome? We usually take history, talk about the chest pain, try to rule out see whether the patient has, if patient doesn't have classical symptoms, how to try to see whether the patient has some symptoms that looks like those angina equivalents I mentioned earlier. We want to rule out other causes of chest pain for the patient, do a physical examination, including a detailed chest examination. They do investigations before you treat. Some investigations that can be done in these patients include a full blood count to rule out anemia, because for patients that are anemic, when they have with anemia, they might be hypoperfusion to several organs, including the myocardium, thereby leading to symptoms of chronic coronary syndrome or symptoms arising from obstruction of blood flow to the heart. Then patients, you can also do a thyroid function test in which you want to rule out thyroidosclerosis for this patient or elevated thyroid hormone, because generally patients with hyperthyroidism can present with elevated blood pressure. They can also have tachycardia. With elevated blood pressure is known to be one of the risk factors for patients with coronary artery disease. They can have tachycardia, in which there is now a mismatch between oxygen demand and supply. You want to do a fasting blood sugar to rule out diabetes mellitus, because it's known that patients with DM, they can present with, they can, most of the time, because of autonomic dysfunction, they can present they usually present without, they can present with other angina equivalent without having the classical chest pain. In order to confirm the diagnosis, patient has diabetes mellitus, you want to do like hemoglobin. However, if you do your fasting blood sugar and HbA1c and it's still non-conclusive of whether patient is diabetic or not, you want to do your 2-hour postprandial to confirm. Then you also want to do lipid profile. It's known that this lipidemia is a known risk factor for chronic coronary syndrome. Then patients with CKD can also present with chronic coronary syndrome. Then we also want to do a highly sensitive cardiac troponin. It's essentially, for patients that presents with chest pain, an ECG must be done for them to look out for T-wave changes, ST changes, whether elevation of the pressure and all that. So then the next you want to do your cardiac enzyme, of which the troponin, due to the fact that they last longer in the blood, the troponins will be useful in patients like this. So, like I said, I want to do a 12-lead ECG, stress ECG. We also want to do a functional imaging for the myocardial perfusion scintigraphy, and stress echo, cardiac MRI. We also want to do the CT coronary angiography and a chest X-ray for them. Differential diagnosis of chronic coronary syndrome includes peptic ulcer. However, for patients with peptic ulcer, even though they present with symptoms that looks like chronic coronary arthritis, they usually present with pain in the epigastrum that can be aggravated by either relieved by food or aggravated by hunger, usually radiating to the back and all that. However, these symptoms are usually, they actually look like symptoms that patients having chest pain present with. However, if you do your investigation or just assess patient for different risk factors, that will help you to tell whether this patient has a coronary artery disease or not. Then acute pericarditis is another differential pulmonary embolism, acute cholecystitis, and aortic dissection. All these patients usually present with chest pain. However, with the characteristics of the pain that they're having, then following the characteristics, then other you have to assess for risk factors and all that. So that will give you a high index of suspicion whether a patient actually has coronary artery disease or not. So how do you manage patients? In managing patients, you have to explain the problem to the patient, reassure them about the ability to formulate a treatment plan, identify and treat aggravating conditions, recommend adaptations of activity as needed, then the treatment of risk factors that will decrease the occurrence of adverse coronary outcomes, also a patient about the drug therapy that are available for them if they're having chest pain. Then if they meet the indication or if they have the indication for revascularization either by PCI or cabbage, then the physician or the cardiologist would advise as such. These are some of the medications that are used in managing patients with coronary artery disease. The nitroglycerin can be in form of ointment, transdermal patch, sublingual spray, sublingual tablet or spray, acesulfide dinitrate. They have the oral one, then the sustained release. Then these are some of beta blockers that are used in patients with coronary artery disease. So calcium channel blocker also has a place in management of these patients. Then for control of their symptoms, anti-angina drugs like adolacin, corandim, then ipradim. Then also antiplatelets and statins also have the place, and patients will also benefit or usually benefit from antacid converting enzyme inhibitor. Then finally, if they meet the criteria and per coronary intervention, per coronary intervention or coronary artery bypass graft can be done for them. So we'll now move to the bit of the matter guidelines. The European Society of Cardiology guidelines for management of chronic coronary syndrome, 2024 guidelines. So the recommendations from history taking and risk factor assessment and vesting electrocardiogram in individuals with suspected chronic coronary syndrome. So in individuals reporting with symptoms of suspected myocardial pain or chest pain of ischemic origin, a detailed assessment of cardiovascular risk factors, medical history, and symptoms of characteristic symptoms as described earlier and recommended. This is a class 1 and level C recommendation, class 1 recommendation. Also, symptoms like chest pain triggered by emotional stress, dyspnea or dizziness on exertion, pain in the arms, jaw, neck, or upper back, or fatigue should be considered as potential angina equivalents. This is a class 2B recommendation. Also, highly sensitive C-reactive protein or fibrinogen plasma levels should be considered for patients presenting with myocardial ischemic pain. Then likelihood, it is recommended to estimate the greatest likelihood of obstructive epicardial coronary artery disease using the risk factor weighted clinical likelihood model. This model usually takes into consideration the age of the patient, the sex of the patient, also symptoms of the angina, the classical symptoms of angina when they present, then also patients, so also dyspnea. Then it's recommended to use additional clinical data like examination of peripheral arteries, resting ECG, resting echocardiography, presence of vascular calcification on previously performed imaging tests to adjust the estimated yield by risk factor weighted clinical likelihood model. This is the class 1C recommendation. Then in individuals with a very low pre-test likelihood of obstructive coronary artery disease, deferral of further diagnostic tests should be considered. So if you take a history from the patient, then from your history, it's unlikely, the history is not really suggestive of coronary artery disease. You might defer further investigations that will lead to diagnosis in patients. So those patients that have very low pre-test probability are not, the guideline is saying that we should not we should not really bother going ahead with investigations for them. Then in individuals with a low pretest probability, this low pretest probability of obstructive coronary artery disease, coronary artery calcium score, that's CACS, means coronary artery calcium score, should be considered to classify the patients and to identify more individuals with very low coronary artery calcium score weighted clinical likelihood. So for individuals with moderate pretest probability, this low is actually can be likened to a low pretest probability. Then the very low, very low can be likened to a low pretest probability. Why a low one can be moderate pretest probability? Why the ones with um, uh, the why the next category that those ones greater than 50% are patients with high pretest probability. So for the patient with moderate pretest probability, he said that coronary artery calcium scoring should be considered to classify the patients and to identify more individuals with very low, to either identify individuals with very low, that's low pretest probability, or individuals with high pretest probability. This is a class 2B recommendation. In individuals with initially low likelihood of obstructive coronary artery disease, exercise ECG and detection of arterial-thoracic disease in non-coronary arteries may be considered to adjust their pretest likelihood estimate. So this is saying that individuals with a moderate pretest probability, they might time you do an exercise ECG and you detect presence of arterial-thoracic disease in non-coronary arteries, may want to adjust them to the next level. That's those ones with the high pretest probability. This is class 2 B, then with level C recommendation. Then ambulatory ECG monitoring should be considered in subjects with vasospastic angina. Because for this patient, want to do ambulatory ECG because usually the symptoms are not there at all time. Symptoms of course stays for some period and patient has some relief. So if you do an ambulatory ECG and patients maybe have symptoms within that period where the ambulatory ECG is being collected with the patient, might see some ECG change is suggestive of an ischemic chest pain. ECG change is suggestive of coronary artery disease. Then in individuals suspected with chronic coronary syndrome and low or moderate pretest likelihood of obstructive coronary artery disease. Hello? Hello?
Hello, Dr. Freedom. We can hear you.
Okay, I just wanted to be sure. Coronary CT. So in the individuals with suspected chronic coronary syndrome and low or moderate pretest likelihood of obstructive coronary artery disease, coronary CT angiography is recommended to diagnose obstructive coronary artery disease and to estimate the risk of major advanced cardiac events. Now, MAC means major advanced cardiovascular events. That's the class 1A recommendation. Then in individuals with suspected chronic coronary syndrome and moderate or high pretest likelihood of obstructive coronary artery, stress echo is recommended to diagnose myocardial ischemia and to also estimate the risk of major advanced cardiovascular events. That's the class 1B, class 1, then level B recommendation. Then during stress echocardiography, when two or more contiguous myocardial segments are not visualized, it is recommended to use commercially available intravenous ultrasound contrast agent to improve diagnostic accuracy. Usually for patients, when they say when you do a stress echo and you don't see some segments very well, so the contrast that usually used for giving to patients for stress echo usually contains some micro bubbles. That micro bubbles, when they get to the cardiac muscles, they tend to expand and improve visualization of both the structure and function of the myocardium. That's the class 1B recommendation. Then during stress echocardiography, myocardial perfusion using commercially available intravenous ultrasound contrast agents is recommended to improve diagnostic accuracy and to refine risk stratification beyond one motion. That's the class 1B recommendation. During stress echocardiography, Doppler of the left anterior descending coronary artery flow reserve may be considered to improve risk stratification beyond wall motion and to assess microvascular function. So with Doppler for this patient, we do a Doppler of left atrial artery set to aid in assessing microvascular function, which mentioned earlier can be a cause of coronary artery disease, usually the non-obstructive coronary artery disease. Then in individuals with suspected chronic coronary syndrome and moderate or high pretest likelihood of obstructive coronary artery disease, the SPECT or preferably positron emission tomogram, that's myocardial perfusion image is recommended. So SPECT or PETs, for this individual, SPECT or PETs is recommended to diagnose and quantify myocardial ischemia with or without scar, to estimate the risk of major adverse cardiovascular events, and also to quantify myocardial blood flow. That's the class 1B recommendation. Then in individuals selected for PET or SPECT myocardial perfusion imaging, it is recommended to measure coronary artery calcium score from an enhanced, that is non-contrast chest CT imaging, to improve detection of both non-obstructive and obstructive coronary artery disease. That's the class 1. There will be recommendation. In individuals with suspected chronic coronary syndrome and moderate or high pretest likelihood of obstructive coronary artery disease, cardiac magnetic resonance perfusion imaging is recommended to diagnose and quantify myocardial ischemia or scar and estimate the risk of major adverse cardiovascular events. So indications for invasive coronary angiography in individuals with suspected obstructive coronary artery disease follows. When invasive coronary angiography is indicated, the access site of choice is the radial artery. That's the preferred site when we want to do, when the cardiac cardiologist wants to do an invasive coronary angiography. The preferred site is radial artery. That's class 1 and the recommendation. Then when invasive coronary angiography is indicated, it's recommended to have coronary pressure assessments available and to use it to evaluate the functional severity of intermediate non-left main stem stenosis prior to revascularization. So invasive coronary artery, outside helping to detect obstruction, it's also helpful in determine some pressures and some functions within the coronary vessels. That's the class 1A recommendation. In individuals de novo symptoms highly suggestive of obstructive coronary artery disease that occurs at a low level of exercise, invasive coronary angiography with a view towards revascularization is recommended as first diagnostic test after clinical assessment by a cardiologist. So if an individual presents with a new symptom, and if you do your pre-test for it's highly suggestive of obstructive coronary artery disease, he suggested that from the guideline, it's advised that we just go straight to doing an invasive coronary angiography so that if there's need for revascularization, it's done immediately. Then functional assessment of the cardiac artery stenosis severity during invasive coronary angiography. During invasive coronary angiography, selective assessment of functional severity of intermediate diameter stenosis is recommended to guide decision to revascularize using the following techniques: the free flow reserve volume or the instantaneous wave flow ratio. Usually, if you use the free flow reserve volume or the instantaneous wave flow ratio, the details of these investigations, I haven't really gone through them. I didn't really go through them to know what is being done, but they are part of the functional assessments that is done during invasive coronary angiography. Then, in addition, these CFR, CF we consider what this abbreviation means. They are somewhere within the presentation as they are considered as complementary investigations. Then, resting invasive measurements of the flow reserve ratio and angiography derived vessel free flow ratio may be considered as alternative parameters. Then selection of individual diagnosis tests in individuals with selection of individual diagnosis tests in individuals with suspected chronic coronary syndrome. To rule out obstructive coronary artery disease in individuals with low or moderate pre-test likelihood. Coronary CT angiography is recommended as the preferred diagnostic modality. Then coronary CT angiography is recommended in patients with low or moderate pre-test likelihood of obstructive coronary artery disease. If functional imaging for myocardial ischemia is not diagnostic. So if you do functional imaging for myocardial ischemia, you are not sure whether a patient has a coronary artery disease. So you can go ahead to do coronary CT angiography for those patients, like those with low or moderate pre-test probability. That's the class 1 recommendation. Then invasive coronary angiography with the availability of invasive functional assessments is recommended to confirm or exclude the diagnosis of obstructive coronary artery disease or ANOCA, that is angina with non-obstructive coronary artery disease, or INOCA, that is INOCA, ischemia with non-obstructive coronary artery disease in individuals with an uncertain diagnosis of non-invasive testing. So for patients that, in order to exclude the diagnosis of obstructive, so what this point is saying that invasive coronary angiography can be done for patients with obstructive coronary artery disease. It's also used because of its effect on assessing the function, that whether there is obstruction or not. It's also used in patients with non-obstructive coronary artery disease. That's the class 1 recommendation. Then in patients with a known intermediate coronary artery stenosis in the proximal or mid coronary segment on coronary CT angiography, CT-based free flow reserve volume may be considered. Then how do we define high risk of adverse events following the guidelines? An initial classification of risk of adverse events is recommended based on clinical assessments using the age, ECG findings, angina threshold, diabetes, chronic kidney disease, or left ventricular ejection fraction. So the use of one or more of the following test results recommended to identify individuals at high risk of adverse effects. One, exercise ECG, that's stress ECG. If due Frederick score is less than -10, patients said to have a high risk of is at high risk of having adverse events. Then, if you do a stress spect or PET perfusion imaging, if you have an area of ischemia of greater than equal to 10% of left myocardium, the patient has high risk of adverse events. Then, if you do a stress echo and you see greater than or equal to 3 of 16 segments, with under this stress echo, if you see hypokinesia or akinesia in greater than or equal to 3 of the 16 segments, patients at high risk. Then, if you do a stress cardiac magnetic resonance perfusion imaging, you see greater than 2 of 16 segments, then patient is at high risk of having adverse events. Then, with dopamine induced dysfunctional segments, if you do dopamine stress testing, patient has greater than 3, as we saw for patients that have stress echo done. You see greater than 30 dysfunctional segment, the patient that risk of having at high risk of having adverse events. Then, if you do a coronary CT angiography, and you see a left main disease with greater than or equal to 50% stenosis, or 3 vessel disease greater than or equal to 70% stenosis, or 2 vessel disease greater than or equal to 70% stenosis, including the proximal left anterior descending artery, then patient has a high risk of having adverse events. Or also, if you see 1 vessel disease of the proximal left anterior descending artery greater than or equal to 70% stenosis, and free flow reserve ratio on CT that the invasive CT angiography is less than 0.8 patients that's high risk of having uh, uh, adverse events. Then cardiovascular, what does the guidelines say about cardiovascular risk factors, lifestyle changes, exercise interventions in patients with established chronic coronary syndrome? An informed discussion on cardiovascular disease risk and treatment benefits tailored to individual patient need is recommended. This is a class 1C recommendation. So the patient needs to be aware of the risk, the benefits of treatment of this condition. So it's a class 1C recommendation. Then multidisciplinary behavioral approaches to help patients achieve health lifestyles in addition to appropriate pharmacological management are recommended. That's also a class 1A recommendation. Then aerobic physical activity of at least 150 to 300 minutes per week of moderate intensity, or 75 to 150 minutes per week of various intensity. So I don't know, when I read through this part of the guideline, I was thinking probably should be the other way. 75 to 150 minutes per week for for moderate intensity, while 150 to 200 minutes per week for vigorous intensity. I felt that should be the case, not what I'm thinking whether there's an error here, but it stands to be corrected by my seniors and colleagues. And home-based cardiac rehabilitation and mobile health interventions should be considered to increase patient long-term adherence to healthy behaviors and to reduce hospitalization or cardiac events. That's the class 2A, level B recommendation. Then anti-angina drugs in patients with chronic coronary syndrome. It is recommended to tailor the selection of anti-angina drugs to patients' characteristics, comorbidities, concomitant medications. So the medications that are given to patients with chronic coronary syndrome, you select medications looking at patient characteristics, whether the patient has some comorbidities, whether the patient is on some other medications. Just like maybe giving the patient that's having angina chest pain, angina pain that's on nitrates, the phosphodiester, the patient will have vasodilatation, hypotension, and probably collapse and die from that. So it is recommended to tailor the selection of anti-angina drugs to the patient's characteristics, comorbidities, concomitant medications, treatment tolerability, and underlying pathophysiology of angina, also considering local drug availability and cost. So the cost of medication also has to be considered in this case. This is the class 1C recommendation. Then ivabradine should be considered as an add-on anti-angina therapy in patients with ventricular systolic function less than 40% and patients with inadequate control of symptoms or as part of initial treatment in properly selected patients. But also know that outside that, the patient also has to be in sinus reading for you to give ivabradine. This is a class 2A and level B recommendation. The indications for invasive coronary angiography in individuals suspected obstructive coronary artery disease. When invasive coronary artery angiography is indicated, okay, I think we've talked about this before. Just take that slide. So revascularization. So move to the next slide. Revascularization. Okay, revascularization in patients with chronic coronary syndrome. Inform and share decisions. For complex clinical cases, to define the optimal treatment strategy, in particular when cabbage and PCI hold the same level of recommendation, a hard team discussion is recommended, including representatives from the interventional cardiology, cardiac surgery, non-interventional cardiology, and other specialties, if indicated, aimed at selecting the most appropriate treatment to improve patients' outcome and quality of life. That's the class 1 level C recommendation. Then it is recommended that the decision for revascularization and its modality patient-centered. So the patient has to be carried along while making decisions on both medications, both investigations, and other lines of treatment. So it's recommended that the decision for revascularization and its modality be patient-centered considering when possible patient preferences, health literacy, cultural circumstances, and social support. So these factors have to be considered, and patients should be carried along when those decisions are to be made. Then in chronic coronary syndrome patients with left ventricular ejection fraction less than 35%, it is recommended to switch between revascularization or medical therapy alone after careful evaluation, preferably by the heart team or preferred by the heart team. Then correlation between coronary artery disease and left ventricular dysfunction, comorbidity, life expectancy, invalid risk to benefit ratio, and patient perspective should also be considered. Assessment of procedural risk and post-procedural outcomes. Intracoronary imaging guidance by optimal coronary, optimal computed tomography is recommended for performing. This basically means optimal computed tomography is recommended for performing continuous coronary intervention on anatomically complex lesions, in particular left main stem, through bifurcations and long lesions. The intracoronary pressure measurement or computation should also be done. And it's recommended to guide lesion selection for intervention patients with multi-vessel disease. Then, also, in doing this intracoronary pressure measurement or computation, this intracoronary pressure measurement or computation may also be considered at the end of the procedure to identify lesions potentially amenable to treatment with additional PCI. And it's usually done during impaired patients also benefit from fair continuous coronary intervention. Then choice of revascularization modality. It is recommended that physicians select the most appropriate revascularization modality based on patient profile, coronary anatomy, procedural factors, left ventricular ejection fraction, patient preferences, and outcome expectations. This is a class 1C recommendation. The mode of revascularization in patients with chronic coronary syndrome. For patients with for left main in chronic coronary syndrome patients at low surgical risk with significant left main coronary stenosis, CABG is recommended over medical therapy. Coronary artery bypass graft should be done alone for this patient because as it is thought to improve survival, this is the class 1 level A recommendation. Then it's CABG also recommended as preferred revascularization mode over PCI, given the lower risk of spontaneous myocardial infarction and repeat revascularization. Then in patients with chronic coronary syndrome having significant left main coronary stenosis of low complexity, in whom PCI can provide equivalent completeness of revascularization to that of CABG, PCI is recommended as an alternative. So for patients with left main artery disease, then if following the investigation, the ID, invasive coronarography that's done, if the interventional cardiologist feels that the benefit that patient will get from PCI is equivalent to what patient will get from CABG, better to just go with a PCI, given its lower invasiveness and it's thought that it's not inferior. And besides, when you confirm that it's not inferior to CABG in patients like this. So management of chronic coronary syndrome patients with chronic heart failure. In heart failure patients with left ventricular ejection fraction less than 35%, in whom obstructive coronary artery disease is suspected, invasive coronary artery Invasive coronary angiography is recommended towards improving prognosis by CABG. Like if patient has ejection fraction less than 5%, so in order to improve the myocardial function, uh, CABG is suggested, taking into account the risk to benefit ratio of the procedure. Then in heart failure patients with left ventricular ejection fraction at 5% and suspected CCS, as chronic coronary syndrome with low or moderate greatest likelihood of obstructive coronary artery disease, coronary CT angiography or functional imaging is recommended. So we want to do coronary imaging, coronary CT angiography or functional imaging to change the diagnosis before going ahead with your chosen mode of management. That's the class one, then level three recommendation. In patients with heart failure with preserved ejection fraction, having angina or the angina equivalent, and normal or non-obstructive epicardial coronary arteries, PETs or cardiac magnetic resonance perfusion or invasive functional coronary testing should be considered to detect aurora coronary microvascular dysfunction as a class 2A and level B recommendation. Then in selected patients with heart failure with reduced ejection fraction, undergoing high risk for complex coronary artery disease, the use of a microaxial flow pump may be considered in experienced centers where those facilities are available. That's a class 2B and the 3 recommendation. Then it is recommended that chronic coronary syndrome patients with heart failure be enrolled in a multidisciplinary heart failure management program to reduce the risk of heart failure hospitalization and to improve survival. Then the aniline saprophylaxis is recommended as replacement ACE inhibitor or therapy in PCS patients with heart failure with reduced ejection fraction to reduce the risk of heart failure hospitalization and death. The management of angina with non-obstructive coronary artery or and ischemia with non-obstructive coronary artery disease. What does the guidelines say about this? In symptomatic patients with ANOCA, that's angina with non-obstructive coronary artery disease, or and ischemia with non-obstructive coronary artery disease, medical therapy based on coronary functional testing results should be considered to improve symptoms and quality of life. Then for management of endothelial dysfunction, which is one of the pathophysiology, the pathophysiology of patients having ANOCA or INOCA. So for management of patients with endothelial dysfunction, ACE inhibitor should be considered for symptom control. That's class 2A and there will be recommendation. Then for management of microvascular angina, said reduce coronary or myocardial blood flow reserve, beta blockers should be considered for symptom control. And for treatment of isolated vasospastic angina, calcium channel blockers are recommended to control symptoms and to prevent ischemia and potentially fatal complications. Nitrates should be considered to also prevent recurrent episodes. A patient with overlapping endotypes, condition of nitrates, calcium channel blockers, and other vasodilators may be considered, so long as they don't have any contraindications to use of medications or they are not on other medications that can lead to some drug interaction that might be injurious to them. It's okay for older female with high bleeding risk, comorbid, and socially to geographically diverse patients. Similar guideline-directed cardiovascular preventive therapy is recommended in women. So, similar guideline-directed cardiovascular preventive therapy is recommended in women and men. So, for women and men, there's no difference in the guideline-directed cardiovascular preventive therapy. Bleeding risk is recommended. Okay. Bleeding risk assessment is recommended using the precise dual antiplatelet therapy score. That's the class 1B recommendation. The attention to interaction between antiretroviral treatment and statins is recommended to patients with HIV, though some of the antiretroviral drugs have some effects, they can cause dyslipidemia. So for patients having chronic coronary syndrome, we want to avoid this medication because we know hypercholesterolemia or dyslipidemia is one of the things that leads to the is an important part of the pathophysiology thing that leads to this condition. Then socioeconomic, geographical, and under-investigated groups. Continued target efforts are recommended to increase delivery of safe and effective cardiac care to all CCS patients, especially those of lower socioeconomic classes, and also to enhance inclusion in future clinical trials of geographical, social, or other groups that are currently underrepresented. Then, when coronary artery calcification score that the findings are valuable from previous chest exams, using these findings to enhance risk stratification and guide treatment for modifiable risk factors should be considered. So, if you use other risk scoring systems like the one I mentioned earlier, that risk factor weighted clinical evaluation score, and you do a CT, a chest CT, then your coronary artery calcium score is suggestive of coronary artery disease. So this helps to enhance risk stratification. So for patients on the previously having moderate rated probability, if their risk factor weighted clinical score is high, suggestive, and they have coronary artery calcium score that is suggestive, they might be moved to patients with high pretest probability. So coronary artery calcium scoring may be considered to improve risk stratification around treatment decision thresholds. The adherence to medical therapy and lifestyle changes. Mobile health interventions using messages, apps, wearable devices are recommended to improve patient adherence to healthy lifestyle and medical therapy. That's class one recommendation. Behavioral interventions are recommended to improve adherence. Then simplify medical regimens like using